She is a wife, mother, and neonatologist. She has a master's degree in bioethics and has completed the National Catholic Bioethics Center certificate program. This background dovetails with her research and ongoing concern for babies born at the edge of viability, for infants and their families affected by in utero drug exposure, and the myriad of ramifications resulting from an abnormal prenatal diagnosis. She has multiple publications in peer and non-peer reviewed journals and has spoken around the country on a variety of perinatal and ethical topics. Dr. Pierucci, a Jewish convert to Catholicism, has appeared on several programs aired on EWTN, including Women of Grace, The Journey Home, EWTN Live, and Pro-Life Weekly. She has testified about the reality of fetal pain and the changing edge of viability. Dr. Pierucci is a member of the Catholic Medical Association, an associate scholar with the Charlotte Lozier Institute, and a board member of the American College of Pediatricians, where she is also the co-chair of the Pro-Life Committee. Dr. Robin.
Good morning, everyone. Yeah, you got to start out with the wonderful Dr. Donna Harris, who's this gentle soul. I am not. I have not been accused of that, so we'll see how this all rolls. All right. So, I see we're going to have that issue. Please? I have a really warped sense of humor, guys, so I really apologize now. Hello, over there. All right, I have no financial disclosures. Are you going to fix, maybe? Cool. No financial disclosures. All parent stories are provided with permission of the parents involved. So a new beginning. You get the diagnosis, the pregnancy, it's positive, and the joy and the terror and the fear and all the different emotions that are part of there's a new baby coming. And then there's utter despair with a prenatal diagnosis. Oh, did it work?
Might have to be a little bit closer.
To what?
To your computer.
Okay, go back.
There you go.
Oh, okay, wait. Okay, hold on. Now we're going to go in order, just because I'm that way. Okay, ta-da! We will get this right. So, prenatal diagnosis, I have seen people completely transformed into utter despair. They are devastated, they are traumatized, the complete lack of informed consent. They were surprised. I've had moms that were literally in the grocery store parking lot when they found out this diagnosis. Yeah, I know. Or their My Chart being, because there was a new test result back and it's 2 a.m. and there's no one to talk to. It's not right. I actually heard from one mother who told me she found out because the office manager screwed up and called to ask her if she wanted an abortion. Correct. So we've got some issues. I can't fix all of them today, but with my mouth, I certainly do make people aware. So, oh, good, it worked. Okay, so Donna talked beautifully about prenatal testing. I will touch a little bit on that. Thanks be to God, she did the statistics. I don't have to play with that. But I do want to talk about the traumatization of the parents and what happens, a little bit about perinatal palliative care, which is my original publications and how that has been warped by our culture of death into becoming a self-fulfilling prophecy. And the lethal language will go through that. That part's rough, but hang on, because, well, you'll hear from moms who actually said, I was given an option of death now or death later. There's support life. We have this option, and there's a growing number of us who are actively involved in helping walk with you so that no one has to be abandoned. And then we'll see how long we have the privilege of carrying the pregnancy and the life of these little people that are inherently valuable. So hang on through the rough part. Okay, so just a hair more about prenatal testing. I won't belabor it. However, this is Aurora. Mom calls her Ro. 13 weeks, Ro was diagnosed with Down syndrome, and her mom said, a future with challenges, sure, but still a future. But at 16 weeks, we met with the genetic counseling and maternal fetal medicine doctor. Quote, that's where the future came crashing down. Due to severe congenital heart defect and hydrops fetalis, so there was lots of extra fluid, in the abdomen and the chest. We were told Roe would not survive the pregnancy. Roe was born at 38 weeks and 2 days. Mom also talks about how she went in complete terror to every single appointment, which was weekly, scared to death that they were going to say, this time I don't hear the heartbeat. And yet at 38 weeks and 2 days, she was born, she stayed in the NICU, the neonatal intensive care unit, for 58 days. She had 3 open heart surgeries, logged several hospital admissions. Today, Roe is a growing, thriving, smart 3-year-old. She kicks balls and walks like many children typical of her age. The future we were never promised wakes up every morning and greets each new day with a smile. This is our privilege when we care about our little ones. So, prenatal testing, as Dr. Harrison so beautifully alluded to, it's a road to death. Let's not pretend any differently. Back in 1956, amniotic fluid is analyzed for the first time. Yep, humans have 46 chromosomes, 59 aneuploidies, multiples, and problems with the genetic code we start to determine. It's 1960 that we get the first reported amniocentesis, but the first amnio was done by 2 moms who were carriers of hemophilia. And the reason that that was being done, they would have terminated their pregnancy if it was a boy. Amniocentesis began as an option to destroy this child. That's where this started from. Nope. Now, quick public service announcement from your friendly neonatologist. Trimesters are embryologically meaningless. We have, in our embryology textbooks, 0 to 2 weeks, sometimes it's called germinal, sometimes it's called pre-embryonic. The initial, when we go from sperm-egg fusion, which is conception, that is medically when life began. It's really not that difficult to discuss that. And it's not religious. That's medically when life began. To the embryonic phase, 3 to 8 weeks. By the end of 8 weeks, some women aren't even aware they're pregnant. Every single organ system is present. The rudiments are all there. They will change in 3-dimensional size and shape and volume and position, but everything is present and accounted for. And then there's 9 weeks to birth, which is the fetal period of development. Now, you know how they're like in 3 cute little even things? No. So that's way back here. That 9 weeks, all the way until term, is the fetal period by definition of the embryologic textbook. That means I care for fetal people. It's not a euphemism. It's the babies in the NICU. My entire job for the last 25 to 30 years has been, how do I help someone go from fetal physiology to something that is more able to breathe with room air and deal with food. Not yet pizza, but we're getting there. But it's not an equal 3. And I got to tell you, I told you, this guy is like, where's Waldo in all my presentations? He shows up somewhere. He's probably 30 and smokes a cigar or something. I don't know. Anyway, so out of old Roe v. Wade, it was the legislators that came up with trimesters, not doctors. And this is unfortunately now in medical textbook and left over today. So this article said, Roe v. Wade legalized abortion in the United States. This legislation developed a trimester framework for gestational age, establishing that abortions in the 3rd trimester could be performed. But let me tell you, the premature baby does not become more human in the 3rd trimester than he or she was in the 1st or at sperm-egg fusion. I've been at 30 years worth of deliveries, and I've never seen a human mom give birth to a platypus. It's a human being every single time. And we don't gain more of our humanity the longer we gestate. We're completely human and completely unique individuals and inherently valuable from the moment of conception forward. So, Dr. Johnson, who's an OB, this appeared in the New England Journal of Medicine of all places, and she said without robust informed consent, and she's referring specifically to prenatal testing, she said patients will be asked to decide whether to undergo invasive diagnostic testing and then to consider whether to terminate, she admits this, or continue the pregnancy without a full understanding of the results. Dr. Harrison just explained why we don't understand squat, really, from the prenatal testing. It's a percentage, it's a maybe, and I'm gonna tell you, it's not that I don't care, but I don't care. Because the prenatal test, even if it is the right diagnosis, doesn't tell me the prognosis. It doesn't tell me how well this baby is going to do. It doesn't tell me about the spectrum of disease, how much or how little they'll be affected. And I don't care because the person's inherently valuable. So now it's about how do we help this little one live well with what we do or don't have the ability to heal. I never want to abandon a parent. I always have an obligation to care. So genetic testing, I kind of look at it as Pandora's box of, oh my goodness, what have we done before we even have the ethical tenacity to understand what we've done. Now, having said that, I have used this in the neonatal intensive care unit when we have a child who is kind of a diagnostic odyssey, meaning we're just doing test after test. We know something's wrong. What is it? Is there something we can do? And we've sent now whole genomes to be able to see, and we've gotten helpful information back to be able to help us, first of all, either stop all the crazy tests, or what do we need to do? Is there, some sort of enzyme we can give? What are we doing? But a lot of times it comes back and it says, I don't know, how's the baby doing? Clinical correlation needed. And I'm like, well, clearly it's not going well, or I wouldn't have asked. So and sometimes you just find out the baby's related to the rest of their family. Great, they're all alive and doing just fine. So once again, all information is not automatically good. We really have to be intelligent about how we use this. And when do we even go looking? Not always easy. So this is a series of articles that I have nicknamed Genetic Misadventures to try to drive home the point. A genetic variant was blamed for causing something called long QT syndrome in an infant who died from SIDS, so sudden infant death syndrome. What was interesting, though, is this little one had a rare genetic abnormality. They tested the asymptomatic, currently fine brother, found he had the same genetic abnormality, and they actually put a defibrillator in this child who was doing just fine, thank you very much. And it did go off a couple times, caused all kinds of trouble. Well, someone finally looked up and tested the whole family. More than 20 family members had this variant, placing clinical doubt on the veracity of the previously levied diagnosis of the long QT syndrome being the cause for that child's death. We don't know what we're doing a lot. A little humility, sports fans. So their conclusion was, more than ever, we must also strive to be wise clinicians who recognize that phenotyping still matters most. In other words, look at your patient. And yet, look what we do when we haven't even met the patient. We make these decisions when I haven't met the child. Doing an ultrasound is not meeting your baby. So, once again, we have come so far. The things that we can see on ultrasounds and genetic tests and all the other things that are now at our fingertips, yeah, they tell you something, but it's not everything. And we need to be so careful about what then our decision tree is based on a human being that we haven't met. So the issue really is that prenatal testing does not lead to diagnostic or prognostic certainty. Another diagnostic misadventure, self-fulfilling prophecy. This is a recent publication. The title is Chromosomal Analysis of Short-Term Outcomes of Prenatally Diagnosed Congenital Heart Disease. I just shake my head just even before I read it. Interestingly, a prenatal genetic diagnosis was negatively correlated with a pregnancy continuation. Duh. Someone offered them to terminate their baby because of a prenatal diagnosis. because it was not a significant predictor for postnatal mortality. Well, no wonder you already eliminated a substantial amount of your population just because you were scared. They went on to say, a postnatal diagnosis of a genetic disorder impacted early but not late postnatal mortality. Well, that's because you found something was wrong and someone said, sign you up for perinatal hospice, and then the baby died. Let me prove to you what I mean. This is a different study by Annie Janvier up in Canada. This, looking at trisomy 13 or 18. Check this out. Prenatal diagnosis. For kids who lived less than 1 day, 36%. No, see if, yeah, oh, there we go. 19% live for more than a year. Look what happens postnatal diagnosis. Only one lived for less than a day. Everyone else managed to live because they were treated like normal babies. They got good care. And a whole lot more went home, 57%. The same exact thing, interestingly, when they were assigned perinatal palliative care prior to birth. Same thing. Comfort care assigned, 56% lived for less than 1 day. Everyone lived if they weren't diagnosed until after birth. 38% of those children went home, 90% palliative care when it was assigned after birth. And we took the time to care about this child, meet the family, figure out what their actual values are, what do they want to do. It's just a jaw-dropping study. And we'll come back to it again. But so back to my friend who published this in the New England Journal. Prenatal testing is a collective fiction that screening can improve a fetus's health, and it's a collective silence regarding the fact that a positive screening result could eventually lead to a decision to abort. That was actually in the New England Journal. It was also in 2017 before other things went a little kooky in our country. So, all right, enough with the prenatal testing. Talking about, and this part's hard, the traumatized parents, perinatal palliative care, and the lethal language, which is part of our culture and we don't even hear it. So this is Luke. His mom, Maureen, says, my son had a number of abnormal findings detected on that routine 20-week ultrasound. He had congenital heart disease, he measured very small, and there appeared to be some neurologic abnormalities as well. No specific diagnosis could be given. His situation was presented as hopeless by our maternal fetal medicine doctors and genetic counseling team, and warranted ending his life in the womb. We were offered grim outcomes, and the guarantee of our son's life would cause him and our family great difficulty and suffering. It always confuses me when a pregnancy is going just fine and a mom says, I was told my baby's suffering or my baby is in pain. As far as I can tell, your baby's listening to your heartbeat, and to you and to your dad and to the other children and grandma and grandpa. The baby's doing just fine. Your heart has been broken by this prenatal diagnosis and the grieving process that's already happened over a diagnosis that I don't know if it's true or not, but the baby's okay. So here's Luke and mom and dad. The harmful and coercive effects of the grim misinformation our family received could have led to his termination had we not been completely committed to his life and continued to seek answers and means of supporting him. And part of that was found by finding Tracy Windsor and Be Not Afraid, and talking to wonderful physicians, Marty McCaffrey, who helped them, and I know many in the audience are associated with. I've had the privilege of also talking with families. We get to care for people. Our son did pass away at 1 month from complications related to prematurity infection, but the 4 weeks we had with him remained the most sacred, treasured time of our life. I shudder to think how differently our grieving process would have been without this time with our precious little boy. Yeah, it's not the same when we invite parents to be complicit in their baby's demise. So defining trauma, SAMHSA calls the 3 E's. There's an event or a series of events or circumstances. This experience is physically or emotionally harmful or even felt to be life-threatening. The effects are lasting. on function and mental, physical, social, emotional, spiritual, and well-being. This is PTSD. It affects you, literally shaking. You can't think straight. Your brain is taken offline. That's legit. A prenatal diagnosis does exactly that. I've heard it referred to as a car crash, a train wreck, an explosion going off. Life stops. There was life before this diagnosis and there's life after it, and trying to figure out the pieces. It's sudden and unexpected. There's no protocols for how to best communicate the results, and quite honestly, we're not prepared for what to do, except that somehow or other, it's part of women's health care to offer them a termination in death. Quality of life judgments are absolutely communicated. We'll talk about that in a second. There's a very scary study that I'm embarrassed about. And the use of lethal language creeps in instantly. I always push back on people who said, oh, have you had a poor prenatal diagnosis? I'm like, why are you calling it poor? They've got a prenatal diagnosis. It doesn't negate the value of this child. So, characteristics of a traumatic event. This is the American Psychiatric Association. They say it happens suddenly and unexpectedly, disrupts basic assumptions about the world and others. And the stressor is usually experienced with intensity, panic, or helplessness. And responses may be numbness, detachment, feeling overwhelmed, arousal, out of control. Everything I watch all of our parents go through. This is a study that looked, is that what really happens if you get a prenatal diagnosis? They interviewed 165 moms, and I love this because they interviewed the dads too. We forget the dads are equally traumatized. Prospective studies, which I love, after they got a diagnosis, 88% of the moms, 83% of the fathers, quote, experienced the communication of diagnosis in their fetus as a traumatic event. There was no correlation between the type of malformation and the trauma, so it didn't matter if it was a small something, a big something. A mom said her baby had club feet and she was offered termination. I'm like, what? I mean, the craziness that goes on out there, you can't make this stuff up. So, anyway, this is the same study. Communication of the diagnosis was sudden and unexpected. 100% of the moms, 83% of the fathers felt numb and did not know how to respond to the diagnosis, plus the gamut of emotions, of emotional anger, concern, loss, grieving, all of the, you would expect this kind of thing when your hope, which is your child, is smashed by a prenatal diagnosis and lethal language. This is a different study that said the key message is the diagnosis of a fetal anomaly is associated with higher levels of parental depression and traumatic stress, and I would agree with the comment earlier, the entire team in the delivery room and what that does, the ripple effect of everyone involved. It's a big deal. And yet we do this routinely. Why? I don't know. Anyway, in particular, diagnostic severity, prognostic ambiguity, and changes in the diagnosis also could increase risk of stress. There was a family, they had already been told that their child had essentially been given a death sentence and they had grieved and gone through loss. A nurse called me and said, they already know this, but is that true? And they had been living and settling in with these facts for a couple weeks by the time I got to meet them. And I had to say, I said, I'm first of all, what's your baby's name? And mom sobbed because it was the first time someone had asked that. I said, so your baby has renal agenesis. We can't find the kidneys, but there's transplant programs at places, and what I can't tell is how well the lungs have developed. And I won't lie, it's not a great chance of survival, but it's not none, and I've been involved with kids who have. The father was irate because someone had pulled the rug out from under him. First, he had dealt with the prenatal diagnosis, which was a complete surprise, and here I was, he had kind of figured out, okay, we're grieving, here's what we're gonna do next. It was awful. So just changing the waters again is equally traumatic, and we really just have to be so sensitive and cognitive of the emotional roller coaster we sometimes put people on. This is a really small study, but I really like the diagram because it reminds us about something else we heard in the audience. People are isolated. How do I even tell my family? Because then I got to comfort my family because my mom is going to cry, and I got to take care of her and my sister and my aunt. And they are utterly alone with this information. And they sometimes just don't even know what to do with that. Just even making the trauma even worse. So we go from newly conceived baby to a prenatal diagnosis, traumatized parents, hopeless, smashed, isolated, abandoned. It gets better, I promise you guys, because I'm not right. Where did we go wrong? Yes, that's me on a bad hair day, post-call. So after all of those things, what I'm going to say next, I want to be careful because everyone makes decisions in the context of what information you have at the time you were given it. Medicine continues to progress, thanks be. So what was a, quote, death sentence once upon a time might not be today. And even when people were offered palliative care, it seemed like the best thing at the time. So I'm not trying to throw everything out the window. I'm just saying that we live face-planted in a culture of death. And so trying to remove ourselves from the sucking pile of woe, what do we do? And that's what I want to speak to about there is another way and being more cognizant of the language that we use. And Tracy will speak more about the ethics, but in American culture ethics, the value of life is really dependent. Is there an imperfection? We really are incredibly utilitarian. If you're not imperfect, we tend to throw it away, including babies. Is the life wanted? The degree of wantedness does not just determine our degree of humanness. That's hard when a mom is terrified about what to do next. But it might echo our degree of humanity for this child, but it's a real human being, whether or not conceived in wanted circumstances. There's different relevance depending on how far along the pregnancy is. We still know this. We are still living under the shadow of old legislation and the trimester framework. Judeo-Christian ethics state, even when I cannot medically heal, I have an obligation to care because all human life is sacred, always. Medical reality is, though I can't fix everything, having said that, I always have a duty to care. I promised to do no harm, and I take that very seriously. So palliative care, and I have to understand, my original publications about 100 years ago were, I've earned all my gray, thank you very much, and I was part of the group of neonatologists who brought palliative care into the NICU because we can't fix everything. So how do I care well? And this is from the National Consensus Project, and they describe this as palliative care as appropriate at any stage of a serious illness, provided over time based on individual patients' needs, not on their prognosis. I was amazed that this is what was said, because that's not how we practice. Boy, if there's we give people a 6-month death sentence, and then we kind of, in the adult world, they kick them off Medicaid and say, your hospice is done. I'm sorry, you're not dead. It's better in pediatrics, but not always. And we have to go to the insurance company to say, I'm sorry, they're not dead yet. I really don't want to be part of that. Could we continue this? Anyway, so offered in all care settings, focuses on what is important to the patient, the family, and the caregivers, interdisciplinary. That is all wonderful. It's not sometimes what I see in reality. So bringing palliative care to babies. In 1982, Dr. Whitfield described for the first time in the literature creating a family room within the NICU so the family could get out from the bays of babies with all the screaming kids and the chaos of and being of alarms to go to a private room and where you could have lots of family members in and they could play music and you could have a baptism. And what I want, and we now routinely have this in our NICUs. We have rooms where we can go and let the family be there. 1990, Dr. Mangerton published, this is the first attempt to help a family actually bring a terminally ill infant home. The problem was we didn't really have good palliative care or hospice for the babies then, so the family had to return to the ER with a dead baby for the actual pronouncement. Yeah, that wasn't a real good feel-good moment. So, and luckily they weren't stopped en route by the police or anything weird, so we knew that needed some improvement. Families needed more support than that. But so perinatal palliative care, when we brought it to our little guys, for me was always about how do I help a human baby prior to birth or afterwards and the family live as well as possible for as long as we have that privilege with pathology that I have to admit that it can't be healed. Now, here's the problem. This is an actual definition I took offline from the Oxford Dictionary for what palliative medicine is. A medicine or form of medicine that relieves symptoms without dealing with the cause of the condition. Oh no, sports fans. Whatever happened to medical excellence as a requirement? Is this reversible? How about we treat with antibiotics if there's infection? How about we evaluate with true intent to give excellent medication? Hey, putting on a ventilator is not a death sentence, and if that helps someone breathe because their airway is collapsed, we need to do so. What are we treating? Are we treating fear of someone, uncovering a disability bias, or a human being and a family who loves them? This is a wanted member. So back to that Janvier study. So we went through how ridiculous it was that postnatally you have a way better chance of survival compared to if you were diagnosed prenatally. And what her conclusions were, parental goals of children with trisomy 13 or 18 were to meet their children, be discharged home and be a family. But having a postnatal diagnosis was the independent factor most associated with these goals. And for the statisticians in the room, independent p-value is there. It's a legit trial. Children with a postnatal diagnosis were treated as any other child until the diagnosis, which may give them a survival advantage independent of palliative care, which is why I completely believe that a prenatal diagnosis is today one of our biggest barriers to postnatal life. Dr. Marty McCaffrey put it this way recently in Medics and Ethics. Perinatal palliative care assists with life-limiting or life-threatening conditions that are focused on improving quality of life and supporting the physical and emotional needs. Perinatal hospice is an expectation that the baby will die. When organizations emphasize perinatal hospice as the primary alternative to abortion for life-limiting anomalies, they're accepting this flawed premise that we can reliably predict the potential of an extended life. Not the case. I missed the crystal ball line in medical school. I don't know if any of my other fellow compatriots got there, but a little humility once again in front of the human being we've not met. I love when the little guys prove us wrong and go dancing out the door. At this point in my career, I think it is a complete lie to say that I know what a fatal diagnosis is. I won't use the phrase. We could have one that's life-limiting. The applause is from having cared for all of you. So, prenatal diagnosis, as we heard earlier, I love when everyone thinks the same. Pope John St. Paul II in Evangelium Vitae says, a prenatal diagnosis presents no moral objection if carried out in order to identify the medical treatment, but all too often it becomes an opportunity for proposing and procuring an abortion. This is eugenic abortion. Life is accepted only under certain conditions and rejects it when it is affected by any limitation, handicap. It's not okay. And proving the point, this is a true story from a mom that Tracy wrote about. The options that she heard that she was offered. Either terminate this life that is already doomed to die, or allow it to die on its own. Those were my two choices. Eventually, palliative care was offered. She says ultimately there was a referral to a palliative care program because Emmy was still alive at 37 weeks, go figure. But even then, doctors offered little hope and advised to forego fetal monitoring during labor, something that is normal in every single other pregnancy. What actually happened? The medical professionals make you start believing that they know what's going to happen. I agreed to not monitor heart during birth. I hate that I made that decision, but everyone made it sound like it was just the right thing to do. But Emmy was born alive at 42 weeks, 5 pounds, 5 ounces. She was discharged at 24 hours with a nasogastric tube, oxygen by nasal cannula, and she lived for 118 days. The doctors were wrong. Yes, we were. So you see what happens with the lethal language and the courage that parents have had to show to fight back. This is a study. Dr. Wilkinson has 2 different studies, one in 2012, one in 2014. On review, there is no agreement on the probability of death that would justify describing a condition as lethal. Could not agree more. Lethality is used for a heterogeneous group of conditions to imply an ethical conclusion rather than a clear prognosis. It obscures rather than aids communication. So this is, I know I break all the rules of good PowerPoint. So what it says at the top is published outcome for severe congenital anomaly frequently described as lethal, and it goes through renal agenesis, anencephaly, thanatophoric dysplasia, trisomy 18, trisomy 13, holopros. I have sent babies home with every single one of those conditions. Not true. And yet, and proving it's not true, check out the survivals. So this is in the same slide. They're called lethal by a lot of physicians, and yet here's their survivals. 13 months, 22.5 years, 5 years, 27 years, 50 years. Good grief. As we alluded to earlier, all of us have a lethal diagnosis. We were born. But it does uncover a quality of life bias. Yeah, I crack myself up. When it's that depressing, you gotta just have silly baby pictures. So many know that life-limiting genetic disorders are compatible with life, but when asked if they are compatible with a meaningful life, the quality of life biases comes right up. And this is, Jacobs did an actual paper surveying of neonatologists and obstetricians. 40% stated they do not think that trisomy 18 is a lethal condition. 16 think it's compatible with a meaningful life. They admit to making a quality of life decision for these families. Not okay. Especially in the same year it was published, this is out of JAMA, it says 15 years survival. I understand a bullet. If you're shot, that you could be dead, that's lethal. Living for 15 years is not lethal, or 20, I think, honestly, that we don't even know how long our trisomy 13 and 18 population can live because we haven't afforded them all the advantages yet that we need to do. So ramifications of the lethal language. Obviously, studies show that parents of trisomy 13 and 18 kiddos describe feelings of anger and disillusionment, a sense of being misled by the healthcare professionals. They've earned it. This is the other thing. Abandonment exists in abortion laws. I have been recently asked, and I know Dr. McCaffrey and Tracy and I have been involved in states that want an exemption for, quote, a fatal fetal anomaly. We don't know what that is. So please don't put it in law that that's a good reason for an abortion. I annoy people all the time. It's great. So abandonment exists in the non-lethal populations as well. Down syndrome is still fighting this, and they live. This is crazy. So this is a study, and when I have a pointer that helps, when I learned that my child, I felt frightened. Well, the parents weren't so frightened, but they completely agreed. Did I emphasize aspects that were positive? Nope. All they heard was bad news. I had a mom once come up to me. She came back to the unit, this little girl who had trisomy 21. She said, "You doctors, you are so good at telling me everything that can go wrong. this is true. I'm a professional worrywart. It's what I am by trade. She said, not one of you told me how much alike this child would be to my other kids. She was exactly right, and I changed how I was talking to folks. Thank goodness that was very early when I was in my career. Okay. But here's the problem of what still goes on. Disability is equated with being, you can't be disabled and healthy. Sick, dying, suffering, defective, deformed, abnormal, blah, all the rest of that. So, prenatal testing and a diagnosis really have become barriers to a postnatal life. Here's the good news. We can support life, as you are all a testament to. Here's Madeline. In those many conversations, by the way, Madeline's mom is a nurse. She understood everything she was being told. She was pregnant with twins. But in those conversations with the high-risk teams, we were presented into doing, at the very least, what they called a selective termination. Her little girl had anencephaly. The part they failed to mention was the unique bond I would have with my daughter, the beautiful moments throughout my pregnancy that are so cherished. You could see her personality loud and clear through every ultrasound. She was feisty. There's Madeline. Not only did she make it to 32 weeks and 5 days, she lived for 1 hour, 34 minutes after she was born. That was the most precious and sacred hour of my life. I could hear her heartbeat and feel her warm skin against mine. She knew she was loved. That is all she would ever know. May we all be so lucky to be loved that well through every nanosecond of our lives. Because our first diagnosis is, it's a baby. And there is no other diagnosis that ever negates diagnosis number one. So option 3 is going through the beautiful door of life, support, caring to natural birth, presuming mom and baby are safe. If we need to keep you safe, this is not mom, let's talk. Everyone needs to be kept safe for as long as we have that privilege. Planning ahead. When we meet parents, we're honest. We don't destroy hope, because there's a lot I don't know. But so we talk about, what do you do if the baby is a stillbirth? And I promise I'll make phone calls, so you don't have to do that. Be Not Afraid models this better than anyone on the planet. If we get to a live birth, here's the goal. Evaluate and stabilize. If the baby responds, we go this way. I'm a critical care doc. I can tell you what not responding looks like, and I'm going to be honest. And by the way, here's the time frame. So if the baby responds, the baby's going to tell us we go this way. If the baby doesn't respond, then we're going to go this way. No one wants to prolong suffering, ever. But we have to give these little ones a chance to let us know with all humility what we don't know before we've met them. And trauma-informed care. You guys, the parents have just been traumatized. They need connection, someone who understands and sits with them and is willing to be with them throughout this. I love this phrase, sacrificial listening, education, collaboration, encouragement, and mercy. So yes, giving parents realistic places to go for good information. But then I don't just abandon, you talk through it. Here's what we know, here's what we don't know. And yes, there's reasons to be afraid, but I don't know everything, and neither do you. And tell me again the name of your little one, so we can make sure we know how to care well. So trauma-informed care is about providing connection and safety that resolves the resolve to flight, oh my goodness, English is my first language, fight or flight response, which is what's involved in PTSD, which regains parental agencies. So parents can actually think straight again to be able to advocate for their children. Agency, which is just a fancy way to say it's the capacity to act individually and make a decision. When traumatized by news of a prenatal diagnosis, parental agency has been removed. Piling onto the moral distress is being asked 4 different times from Tuesday, do you want to terminate? No. But in the heart of the crisis, one's cognitive capacity is physiologically eliminated. And we're asking people to make life and death decisions, which is crazy. So, what things that we can ask, and I love this series of questions to be able to give parents so that when they kind of get, here's what things you can ask. What is the diagnosis and how certain are you of this? What's the likelihood of survival beyond the newborn period if you do give life-sustaining treatment? What's the likely duration of survival if this treatment is provided? What's the range of physical or cognitive impairment? No one wants to be fooled, but what do we know and what do we not know? And what do we need to find out? And what's the burden of treatment if I want to keep this baby alive? Taking home a trach is no small thing. Is that possible? So I am running out of time because I talk forever, but there are the areas of uncertainty, as we heard about earlier, are just awful. But helping to get through those areas, that helps everyone regain their balance in these crazy waters when you feel like you're drowning. Reduce knowledge gaps, give real information, give a relationship so people don't have to feel abandoned. Collaboration and planning, it's a joint game. That helps provide understanding. Referrals, we go with parents or make calls ourselves. Once again, or listening in on a phone call if you're afraid to go to a referral appointment. And then we reevaluate. Okay, the baby's doing better, the baby's doing worse, where do we need to go? Gift giving. This is a real person. I love this, even before the baby's born. It's given parents permission to choose a name, to talk to family members. They're a tangible person. And I'm going to kind of quick, I'll leave time for, I don't know if I'll have time for questions, but it really is about embracing parents with a community that extends to the community, the hospital service, collaboration with other families. All of us are needed in this adventure. So navigating fetal concerns, the foundation that I have founded, it's all about accompanying parents, recognizing babies' inherent value, and assist the healthcare professionals from being dingbats. I say that. Be not afraid. Also, you know, they started this and have taught me so much. Again, walking with people so that no one is abandoned in this little endeavor. That's how to get hold of us. Because the biggest thing is that everyone, even on this journey that no one would choose, love exists. Thanks so much for your attention, you guys.